StepOne. Go ahead. Rahul, it's your turn.
Great, thank you. And hello, everyone. I'm Rahul Gupta from Project StepOne. Thanks so very much for joining us on a Sunday. And I want to start by thanking all the doctors and health professionals who are guardian angels. Thanks so very much for standing by in these tough times. Today, we would particularly be talking about how Kerala has tackled the situation very well and what could we learn from the Kerala model and apply locally. Before we begin, I would like to share what is Project StepOne, the organization that's now one of the largest associations of volunteer doctors, technologists, and volunteers coming together to fight COVID-19. StepOne essentially plugs into government helplines like 104 and filters down COVID-19 or mental health queries and connects them with the doctors that are volunteering with Project StepOne. We now have a little over 6,000 doctors and mental health counselors that have registered to volunteer with us. And in the past 4 weeks, we've been able to find over 4,000 high-risk COVID-19 suspects that are either being tested or being quarantined. Not to take any more time, I would like to introduce our esteemed moderator and panelists for the webinar today. May I introduce Dr. Arun Gupta, who's an Executive Director, Hospital Networking and Quality Assurance at NHA. Dr. R. Chandni, member of the Kerala State Expert Committee and State Medical Board. She's also been the nodal officer during the 2018 NIPAH outbreak. We have Dr. Midhun Mohan, who's an Assistant Professor, Emergency Medicine at GMC Calicut, and Dr. Vimal Rohan, who's an Assistant Professor and Deputy Medical Superintendent, Emergency Medicine at GMC Kannur. Without further ado, I would hand it over to our moderator, Dr. Arun Gupta, to take it from here. And I request you to type any questions you may have in the chat on the right side. Over to you, Dr. Gupta. Thank you.
Thank you, Rahul. A very good evening to all the participants of this promising to be a very interesting discussion. So in a pandemic like this, what is happening inside the hospital is one part of the response of the society. The other part, which is what is happening in the community, becomes more important because it's not only the treatment which is being provided to the already sick people, but how you are handling the situation in the community, which becomes more important because that determines how many patients are going to land up in hospital requiring treatment. That part, if I can say, has been handled very well in Kerala. And when Rahul came up with this idea of sharing the Kerala experience, I actually jumped upon it because Kerala has actually shown that this pandemic need not be let run through our society. And actually Kerala has been doing it with quite regularity. If I can remember, then Rahul also mentioned it, that even in the times of NIPAH outbreak and other diseases, Kerala has been quick to respond and it has been able to contain it and quickly extinguish any chance of community transmission. And we are very lucky that Dr. Chandni is here, who actually has been the nodal officer for the NIPAH outbreak also. So I will request Dr. Chandni to kindly enlighten us that what is it that the Kerala is doing rightly, how it keeps itself in a state of preparedness so that it is able to quickly mount a response and quickly establish the network of healthcare providers who are there to provide help to the community. Over to you, Dr. Chandni.
Thank you for this opportunity of this good interactive session. And I must say I have no conflicts for this presentation, and whatever I say today or present today is all my personal opinions or views, and from my limited experience, because we are all in the midst of COVID-19. All will have to share our own many interesting experiences, because we have been tackling it so very efficiently all over the part in India. And I'll first start with our experiences during NIPAH in 2018. To be exact, it is in May 2018. And in May 2018, we had a case which was diagnosed with, this case was diagnosed because this patient was hospitalized and there was a family clustering of similar illnesses. And we had a very brilliant clinician who had the prompt suspicion and virologist to support. So all the team together helped us in identifying this pandemic, this outbreak at the very beginning. And to be exactly what happened during that period, we had about total of 23 cases. Among these 23 cases, the first case, that is the primary case, then the index case, and totally we have been having 18 confirmed cases and 4 cases probable because of the epidemiological link. So there is total of 23 cases, and I should say we had only 2 survivors for that outbreak. So this was happening, and when this was first detected, the response was prompt, because we knew that there is human-to-human transmission, there is high mortality, and when we came to know about the outbreak itself, 2 of our healthcare workers already affected. So this was a major response from the Kerala, and the participation from the government, from the tertiary care treating facility, and the community participation, and from the public health system, everything was very so prompt, because this presentation was so alarming because of increased death happening in the hospitals. So we had major challenges at that time. We were never exposed to a disease with such human to human transmission. We were experiencing with many outbreaks, but this was different. So we needed to prepare ourselves with infection control practices, which we all in India has already learned now with the PPE, N95 and all those things. We had an opportunity to prepare ourselves. And we also had to see that hospital patient care and their attenders, and none of our healthcare workers are getting this infection from the hospital. There were a lot of new trainings happening. And the other major concern was the safety of our healthcare workers. This is a major concern even today. We will be hearing from many of our doctors or healthcare workers, because how difficult for them to work in their situations. So all these things we had an opportunity to learn, and we had an opportunity to practice what we have learned. And we were fortunate that we didn't have any new hospital acquired infection out of this outbreak. So that was that should be considered as an achievement, because we were really worried about the hospital care workers infection. So there was no cases among health care workers, and it was a big challenge for all of us, but it was a big learning too at that point of time. And the system was tuned and geared for tackling this outbreak, and an outbreak where we need to identify and isolate these cases from the hospital setting itself. And in 2019, what has happened? We had another patient in Kochi, and we had the similar response that has raised in the entire state. And the entire state was prepared for handling this sort of epidemic and this sort of an outbreak where there's human to human transmission. So the training and retraining of all these things, PPE and other N95 use, and what should be the infection control practices in the hospital, how we should be doing the contact tracing, how we should be line listing, all these things happened during 2019 also. So these 2 outbreaks has really geared up the system, and this has helped us a lot more for Kerala to tackle the response. When the first case that has something is wrong happening in Wuhan itself, the system was gearing up, and we were really planning from the institution wise and the state wise for tackling this outbreak. So this is how this whole thing happened. And there was a huge community participation also. Maybe we can discuss it later. Thank you.
Thank you, Dr. Chani. Thank you for, no wonder that one of my class fellow told me during my final year that if there is anything positive about health indicators, and teacher asks you which state does have the best indicator, then without any hesitation, say Kerala.
Thank you.
So it's because of people like you that Kerala seems to be doing so well. And yes, so it was on December 31st that Wuhan Municipal Commission actually reported a cluster of pneumonia cases to WHO. And on 17th January, the Government of India, Ministry of Health and Family Welfare, took note of it and started taking measures, started advising states. And it was incidentally Kerala which got the first case of lab confirmed COVID-19 on January 31st. And subsequently in next 3 days on February 2 and 3, it got the second and third case also. Despite that, the Kerala could successfully ensure that there was no establishment of infection in the community, and it was a full 1 month before the next case was reported in Kerala. So to talk about that, I would request someone who was actually among the first responders to this pandemic in Kerala, Dr. Vimal, who is working in the medical college adjacent to Kasargod district, which got the first case. Dr. Vimal, please enlighten us on the first measures that you took. Dr. Vimal, you are on mute. Kindly unmute yourself first.
Okay. Thank you, Dr. Gupta, and it's a pleasure evening so that everybody can discuss regarding the current pandemic and we can share our inputs, and let's try and hope to improve the quality of care which is provided across the country. Now, again, as Dr. Chandani said, these are my personal opinions and the personal experiences. Thus, I don't represent the state of Kerala, and there is no conflict of interest here. Now, regarding the initial surge, just like what Sir said, when Government of India realized that on around January mid, that there is a surge of cases in China, Kerala immediately responded because we previously, like Dr. Chandani said, had two experiences. So we had started mounting our training programs and other things. And by January 30th, we had the first confirmed case in Kerala. These were medical students who were returned from China, to be precisely from Wuhan. So the first person was detected positive around January 30th or at Thrissur, and there were 5 people who were traveling along along with him. So the next set of patients, one was admitted in at Kasargod, and that particular patient became positive 2 days later on March 2nd, and that is where our district as well as medical college actually started mounting the response. The most important part is the contact tracing, and even while contact tracing, we realized that there was a person who is in the adjacent district Kannur, where the medical college situates, and that particular person is a contact, and we immediately isolated the person within our hospital itself, and eventually that person turned out to be negative. But what it helped us in the entire perspective is to understand regarding, again, just like Chandani madam said, regarding the contact tracing, as well as we had an elaborate tracking of how the patients came, including the interstate travel they had, and wherever they stayed, everything was traced back. And between the health services as well as medical education and the hospitals identified for admitting, everything was done in a very coordinated fashion so that we can avoid the spread of the disease. Even the close relatives and people who have interacted with these positive cases, as well as the people who have traveled along with these people, was identified, was given, asked to do home quarantine. And the first thing what we did was to say that the quarantine was for 28 days rather than for 14 or 7 days, which was said to be the actual average time of incubation period was 7 days. Usually double the time was 14 days for usually what we say for quarantine. We actually quadrupled it so that we can be very sure regarding the fact that the person doesn't transmit the disease. And there was clear guidelines from the state and from the health sector as to how that home quarantine can be done, and what are the strict measures which has to be adopted. And the previous experience of virus outbreak has already alerted the Kerala public as to why it is so important to make sure that we actually listen to the healthcare workers and how it should be responded.
Thank you, Dr. Vimal. So it is really heartening to know that Kerala population actually listened to the health workers, and no wonder, because Kerala was among the first states. Kerala was rather the first state to achieve 100% literacy, and as Dr. Vimal was telling, uh, actually Kerala started preparing much before, and on 3rd February itself, actually Kerala state had declared a state of emergency, health emergency. And it was not as if it was only just overreacting. On 17th, when there was no further case reported, Kerala actually declared that uh, the state of health emergency is over. So Kerala state was actually responding, was actually dynamically seeing the things proactively, uh, taking steps, and literally it was ahead of the curve. So in a pandemic like this, there are various measures that a government has to take, legislative measures. Then you have to take out certain orders. You have to give some advisories. You have to train your health workers. You have to actually educate your public about the pandemic and what is happening and how it is panning out. So all these things are very important, and Kerala actually took out a series of orders before anyone could even think about it. And to know more about those orders and trainings, I would request Dr. Midhun to enlighten the audience about how the government of Kerala went about it.
Thank you, Dr. Gupta. Now, if you look at the Kerala government website in the Directorate of Health Services, you can see that the first guideline was produced even on January 5th, much before the national guidelines came into being. And if you look at the website, you can see that there are around 70 documents, which include guidelines as well as advisories, which actually form the master plan that help to contaminate, that help to help us to prevent the local transmission of the disease. So if you go chronologically, we will just go through some of the most important documents. First one and the most comprehensive one was guideline on novel coronavirus was produced on 26th of January. This was actually a call out from the government, from the state government, to intensify our surveillance system through the IDSP network, to identify and isolate all the COVID suspect patients by implementing screening strategies at all the point of entries inside the state. This was the major airports as well as the waterways as well as the roadways. Okay, this guideline also provided the protocol on the intense and as well as the systematic contact tracing process to be implemented, pre-hospital preparedness, particularly a three-point triage system, which we had actually implemented during the NIPAH time as well. And it also mentions about the infection prevention and control strategies, and also the SOP for all the field surveillance activities. This was actually the major work based on which the initial surveillance system was activated at that time. Now, after the first case during on January 30th, and the second case on February 2nd, the medical boards were instituted at institutional levels as well as state levels to plan the management of these patients. And on February 3rd, you can see that the RRT, state level rapid response teams, were also started with Shaila teacher, the health minister as the chairperson, and state level committees were also formed. A coronavirus control center was started at the state capital, which comprised of about 18 committees to which formed and coordinated all the components of the healthcare system. Now, on 12th March, by this time, on 12th March, by this time, the infection has spread to other countries. So we again modified our case definition criteria to identify the case suspects. An addendum was produced on 12th March to include those patients as well from other countries rather than just China. And we actually categorize patients into 3 classes: category A and B and C. Category A include mild infection only, category B moderate infection, and category C had severe infection. Category A didn't have to undergo any testing and they would require only home isolation. Category B, they require testing and they could be admitted or they could be managed by home isolation. And finally, category C, they also require testing and had to be isolated in a COVID hospital. So this was the strategy which was implemented at that time. Then on March 23rd, a major awareness campaign was started. It was called the Break the Chain campaign to increase the public awareness about hand hygiene. And this, in a way, I think it has helped us a lot to control the infection and community transmission and increase the awareness among the public. Then on 24th March, we have produced a detailed treatment guideline, which include all the drugs, which was already on evidence-based and as well as on experience, which was prescribed by the WHO as well as other major organizations. And this guideline was followed throughout the state on the treatment of patients. Then on 26 March, we had produced guidelines on the rational use of personal protective equipment. On 28th March, we have produced mental health guidelines for those people who have been isolated, for the elderly, for the healthcare providers, all the people who are affected by this. Then on 31st March, another comprehensive document on how to convert a hospital into a COVID hospital was produced. Now, this helped us a lot to plan. We actually divided the healthcare facilities into 3: the COVID care centers, then the first line treatment centers, and then dedicated COVID hospitals. COVID care centers took care of asymptomatic people, asymptomatic suspects, you can see. And first line treatment centers took care of those belong to category A. And category B and category C were managed in dedicated COVID hospitals. The guideline also says a lot on how to manage the manpower, your human resources. And then in 1st April, again, an addendum was published to include into the case suspects, those people coming from within India, there were community spread. Okay, this was published in 1st April. And between 10th April and 14th May, you can see that a lot of advisories have been produced on how to test using different testing modalities to diagnose these patients for rapid by using rapid test kits and all those things, and how to detect community spread is there or not. So these are the major things. Now, as Keralites are being brought back from other nations as well as other states back to Kerala, you can see a lot of advisories are there on how to contain the disease when these people come, what all measures have to be taken, what all orders they need to follow. You can find all these things in the Kerala government website. Thank you.
Thank you, Dr. Midhun. So these guidelines that you have mentioned, so there were health measures, there were airport safety protocols, precautions by malls, saloons, office hours. There were guidelines about office hours. There were guidelines about migrant workers. There were meetings were actually proactively cancelled, that no meetings will happen in government offices. even the private establishments and factories had given extensive advisories how to manage their affairs. And all these things were at the same time being backed up with action at the community level also. For example, Kerala was among the first few to think about the food security of the migrant workers. Kudumbashri, I think you started very early in the response. And that actually ensured that there were no, apart from some sporadic incidents, there were no large scale protests by the migrant workers in the state of Kerala. So that was really heartening. And in fact, there are heartwarming stories there were of migrant workers refusing to come back to their home states. And they said, we are more safe here. That is something which was really good. And I'm sure there must have been a lot of trainings also in the state. So I would request Dr. Vimal about what kind of trainings were undertaken for the health workers, for the community to be educated about. And I'm sure you would like to tell about those apps also which the health workers were using, and about due to which the Kerala government as well as the public exactly knew what is happening in the state. So Dr. Vimal, would you like to enlighten us on that?
Yes, Dr. Gupta. The thing was, after the initial wave, which happened in February, and we got only 3 cases, even after extensive testing, and we just had a single center. So regarding testing, what we did was, as Dr. Mithun was saying, even just as parallel to the academic sessions and the advisories was coming, we have tried to maximize our testing centers. We tried to acquire ICMR certifications to our virology labs across all the medical colleges. That was one thing which has actually helped us to control the thing, find out to do more testing. And the next thing what was just like what you said, that regarding the transparency. So every day evening, health minister, initially it was the health minister, will give a small half an hour talk regarding what is the state of affairs, how the state is doing it, taking the measures, and why the measures specifically has been taken on what regard. And since we have a vibrant population of Kerala across various countries, and we have been having feedbacks from Italy and other European countries, and to an extent by early March from America also, the actual worst case scenarios which is happening. So even the population, Kerala population, also realized the fact that even the best healthcare systems in the world is unable to cope it up, and it's up to us to make sure that we follow these guidelines. And we have a separate Government of Kerala app on which there is separate sections even for healthcare workers. There is a separate section regarding advisories, so that every person, suppose if you are somebody who has come from abroad, and there is a separate section which in there are guidelines regarding as to how to maintain the home quarantine, which was later rephrased as room quarantine, because home quarantine, essentially people, we have realized that people are coming out of their rooms. So such minute aspects was taken into account while planning for isolation. And regarding the community kitchen and Kudumbashree units, migrant workers, there was a sporadic incident, and immediately that was identified as a concern from the migrant workers, and those things were incorporated. Whatever their requirements were identified, and they were met through the government facility itself, so that there is no such events which happens. And like you said, people who have got treatment from Kerala, eventually foreigners, they were reluctant to go back even to their own countries because of the fact that they felt that it's much more safer here. And there has been an extensive public-private partnership, even in healthcare workers and other things, because when the training happened, everybody realized that what are their limitations, and this, just like advisories to the factories, the government health workers, whomsoever is in the office workers, initially we said that 50% of the time nobody, 50% of the faculty of the office work will be on leave, only 50% will come, and how they should come and what are the precautions which has to be taken. The earlier usage of masks, and when we realized that the prices of masks were going up, uh, there was extensive videos even from the government side to how to create cloth mask and how to disinfect it, how to make sure that you are maintaining safety. And the break the chain campaign, which was done midway through March, was exactly for to make sure that there is no propagation of the disease, because flattening the curve is a term which is known to most of the Keralites, because that was extensively told and made to understand, and the importance of why the public participation is the only thing which is going to help us to make sure that the situation doesn't escalate. So that is how the things have happened. And regarding training, the importance of training is it was extensively trained so that when the second set of cases which happened at Pathanamthitta in early March, even though by February last week, third week, all the three cases were turned negative, and the second set of patients, when they came with a mild fever from the primary health center itself, the doctor had a suspicion. They took a detailed history, and immediately it was picked up that they had a contact from a person from a family who had come from Italy, and they were tested, treated, and isolated, and extensively Pathanamthitta went in for a extended lockdown early in March itself to identify and localize every single person who has been in contact. So the importance of training is every single walk of society, not just healthcare workers, was trained to make sure that they are always in a state of alert so as to avoid propagation of the disease.
Yeah, thank you. In fact, Kerala declared lockdown one day before the national lockdown was announced. So that was interesting. And breaking the chain, again, a very catchy phrase. And just to inform the audience, the Kerala has on date 22 ICMR registered labs for real-time PCR testing. I think it is the maximum in any state of India. So yes, after this, community participation and all those measures, let us turn our attention to the fact that a lot of hospitals across the country had to be converted to a COVID-only hospital. And Dr. Chandni, being a medical superintendent of a very large hospital, who else will be in a better position to tell us about what are the challenges that typically a hospital faces when, from being a multi-speciality hospital, it is told to just accept and treat COVID-only patients.
And
Madam.
I think it's a very big challenge, and it would have been the same anywhere in India. That many of the hospitals would have experienced the same challenge once we have been converted into COVID-only care centers, because especially tertiary care centers are the only place where the middle income or lower income people are coming for multidisciplinary, multi-speciality problems. So there will be a lot of challenge once we say that we are not going to take these patients and it's going to be a center for COVID care only. And in fact, at that point of time, usually there will be a standstill for most of the other concerns, especially other comorbidities, malignancies, which is requiring urgent attention, as well as in pregnant ladies with their problems. And all this will face problems. And it is something we have to address more. If we have to go through the same exercise again, we should be prepared for taking the other comorbidities in a better way. And it takes a lot of infrastructure development and commitment from the administrator side to make it into a COVID only care center. And at that point of time, we should be able to tell what the other people, that is non-COVID people, should go and what will be the care pattern in the facility. So it should be facilities identified, and the people should be able to approach in for their non-COVID care needs. So we shouldn't feel that it's only for the COVID care all dedicated, but they should have the facilities for non-COVID care also. And other major concern, we all know that COVID-19 is a disease where there is pre-symptomatic or asymptomatic people can transmit infection. So we have to be very careful, and we need to have the fever triaging properly, and no patient with the possibility of having this COVID should reach the common emergency medicine casualty. They should not be approaching the ED department for their care. So these things are to be taken care of. Another important challenge is always protecting our own healthcare workers, patients, and attenders, and their assistants who come and support them. So we have to be very careful about this. And it is always very difficult and a challenge for a tertiary care center to be practicing only as COVID care center. So slowly we'll have to identify our smaller centers where they can have the first line treatment and all those things can happen there. So that slowly we can move with COVID and non-COVID together, because we need to have a plan for these non-COVID problems also. So the institution should move in such a way that the COVID care will be provided, especially for seriously ill patients. But the community, the other people coming to the hospital, we need to have a separate plan and facility so that we will be protecting them from developing the disease, and they should not be coming to the area. So this is a pandemic period, and all of us are learning, and we will be able to come up with more ideas to do this better for our patients. But my concern is we should be looking after non-COVID issues also, especially in tertiary care center, and we need to have our own plans depending upon where we are working. So this has to be designed for the institution, and it has to be approach from everyone depending upon their needs and necessity. Thank you.
Yeah, thank you. Yes, you have brought in a very important point that we cannot stop care for other diseases. But before I ask this question to the panel, I would like to inform the audience that you can type your question in the chat box of your computer, and after about 10 minutes, we are going to start taking up the questions. So please type, if you have any question, please type in the chat box, and that is going to be taken up by the panelists. So, madam, you just mentioned that you cannot stop the care for other diseases for a very long time. In fact, WHO and other bodies, the other public health specialists are also emphasizing that you cannot stop other care for other diseases. In fact, Kerala government had stopped the routine immunization during the last week of March when the lockdown was started. But then it actually came out in May, on April 16, I see, that they took out an advisory that routine immunization should start. So what are your thoughts on how you can continue to provide care for the other diseases?
That's why we have to plan it, and the main thing was immunization was an important issue at that point of time, because we cannot delay such things, because once the cycle is broken, it's going to be more harmful than our COVID itself. And the other thing is we can separate the institution into two parts, where we can facilitate only for COVID care in one side, but the other issues like multidisciplinary surgeries and all those things can happen in the other side. But institution has to find out separate areas so that the fever and related things will not come to the other side. But always there is a challenge. Asymptomatic cases can be a problem. So we need to take extra caution, and we need to have a better history taking and other things. And if we have any doubt, we need to have extra protection. And you can even have COVID or COVID suspect theaters and COVID suspect wards, where even if we don't have a definite history, we can. And we also our guidelines, state and national guidelines say that we need to have extra caution for severe acute respiratory infection, influenza-like illnesses. There are advisories. So if we go with that, it may not be a big challenge, but we have to provide care for other things also. We cannot stop for a long period of time.
Yeah, so yes, although we are looking at the macro picture, but still I'm tempted to ask you one question. So when your hospital was converted to a COVID-only hospital, did you find any ego issues? For example, cardiologist or a neurosurgeon walking into your room and telling you that I am a neurosurgeon, I am trained to do surgery on the brain, I will not look at these infectious disease patients or something like that?
It was not like that. We were, in fact, immediately what we did was we have a dedicated area for COVID care. And that area was identified to see primarily this was done by medicine, pulmonology, emergency medicine, anesthesia. All these people were in the forefront for taking, but other departments were also willing to take duty. That was not a big issue, and most of the other problems like cardiac problems, often pulmonology or nephrology related medical problems were primarily tackled by them. So the medicine department burden was a little bit reduced, and this was not a big issue. If they were posted, they were willing to work. But obviously, junior colleagues were putting the whole lot of efforts to be in the on duty during these days.
Okay, okay. In a pandemic like this, when there are extended periods of lockdown, there are bound to be mental health issues cropping up. And Kerala is a state which has one of the highest suicide rate also. So any special measures that were taken to take care of the mental health issues during this time? Dr. Midun, will you like to take that question?
Yeah, sure. The government has done a lot of things to take care of the mental health challenges during this period. The first and foremost thing was to start a 24/7 daily health helpline, which was called Disha. It's for district intervention system for health awareness. Okay, it consisted of dedicated team members who are trained professional social health workers as well as counselors who addressed any questions from the public within the state, outside the state, or around the world. Okay, it has helped them a lot, and it has also helped the healthcare providers also, because there was a lot of confusions till all the guidelines were coming out, and still there are confusions as the pandemic takes into new phases, and this helpline has helped us a lot, as well as the public. So that's the first and most important thing. Then after all the state level committees were formed, a special committee called the psychosocial support team was formed, which actually consisted of 1,107 healthcare personnel. Okay, they were providing the psychosocial support as well as counseling. They called all the people who are made to undergo isolation, either institutional isolation or home isolation. They used to call them every day, and till date I think they have made about 9 lakh calls to these people. Okay, and they have also come out with guidelines on how to take care of the mental health of elderly, those people in isolation, and all these have helped. And just like what Vimal said, the transparency of the government also helped to alleviate the anxiety as well as the fear of the public a lot. Every day the CM would come in, the health minister as well as the chief secretary. They would hold press meets, and they would declare the number of cases each days and what all precautions have we have to take and what are the future plans. And this has sort of helped us a lot, because the leaders, you can see the leaders appearing very calm. Okay, uh, this creates a good impression for the public as well. So right now, I don't think there are many reports of suicides from Kerala uh, among people who are in isolation right now.
Okay, okay. Thank you, Dr. Midun. So we have a lot of questions coming in from the audience. But before I take that up, there is one important question that I would like Dr. Vimal to respond to. In these times, transportation has been a big issue. We have had news about pregnant ladies delivering in the vehicle of SDM, and people not able to reach the hospital in time. And so any special measures that were taken to avoid these kind of situations in Kerala?
Yes, the first and foremost thing was just like what we had discussed, the training of how to transport people even in private taxis or in ambulances was given to taxi workers as well as ambulance workers right from February onwards. And by March, when the second wave started, the government of Kerala had brought out a notification stating that the 108 ambulance, which is the conclusive ambulance service in Kerala, will be utilized for COVID suspect patients. Whether it's a COVID positive patient or a suspect patient, if any transport is required, then we will go to the house, pick up the patient, bring to the hospital, and once the care is completed, and if the patient needs to go back to home isolation, that also will be done using the 108 ambulance service. And there, once the service started, there were so many other voluntary organizations who also joined in, and they were also trained. And for the all the COVID centers, we had assigned a couple of ambulances and these taxi services who were volunteers, and they were trained, and they were made sure that there is no cross contamination while the transport was happening. At any point of time, there is a helpline number with which you can call. And just like what Mithun said, the healthcare workers has always been in constant touch with any person in quarantine, and they have their personal numbers of their ASHA workers or their junior health inspectors, which they can immediately call. Suppose a patient who does not have any symptoms starts to have cough, and there is some breathlessness, and there is some increase of symptoms, they can immediately call the respective person, and they will make sure that the transportation is arranged according to the kind of healthcare setup which this particular person requires. So there is no major confusion regarding transport. I think one of the major important factors regarding control of disease process through the public sector, through the public uh, transport buses and trains and other things, advisories was clearly given, and how to transport people in isolation and COVID suspects as well as COVID positive patients.
Okay, okay. Yeah. So before I start taking up audience question, I would like to remind the audience that we have actually deliberately kept the clinical part of the COVID-19 pandemic out of this webinar. We have the objective of this webinar is to actually share the practices that were utilized in Kerala to effectively treat the community part of this pandemic. How Kerala could ensure that despite having the first 3 cases of the country, still it is very much in the table on the lower side. So I would actually be avoiding those questions which are asking about the clinical protocols, and I would be taking up the questions which are actually important from the community side. So the one question that is interesting. So the telemedicine initiatives, has there been any telemedicine initiative? Because it is very important in these times when a disease is transmitting from person to person due to close contact. So has there been any telemedicine initiative taken in Kerala?
Yes, telemedicine initiatives were there, and telephonic consultations were also considered. Some of the and through in IMA, and there were initiatives through hospitals, individual hospital level also it has been organized, and most of patients were also encouraged to have a telephonic contact, especially those patients who who are on treatment for chronic conditions like diabetes, hypertension, mental illness, and depression. All those things they were ensured that they should not discontinue the medicine, and they should do whatever monitoring like blood glucose and blood pressure from home. And but it was also ensured that because of COVID they should never refrain from attending the hospitals if they really have any seriously ill patients. So telemedicine and telephonic consultations were encouraged, and primarily to reduce the hospital visits, for especially the routine visits. Thank you.
Yeah, so during these times, crowding of hospital will be disastrous. So we have to ensure that there is no crowding in hospitals also. Not only on the streets of the city, but in hospitals also we should avoid. In fact, we should keep appealing to the communities that if in case it is not urgent, it is not important, if you can actually avoid it, please don't go to the hospitals. and role of telemedicine is definitely there. So a lot of audience want to know more about how contact tracing was done, how Kerala could ensure that the R0 rate was kept in check. So that is something which audience are asking. Dr. Vimal, I think you did the first contact tracings. So would you like to take that question?
Yes, sir. Regarding contact tracing, the moment a person from outside country, it was initially outside country, then later presently the outside state, person arrives, healthcare workers actually track these patients. The contact of the person is carried out. They were given clear instructions as to how they should maintain isolation. And suppose at later stage, if a person becomes positive, then what we do is we technically trace back for the previous 2 weeks as to what and all, where and all the person has been traveling, how the person has traveled, just like the initial case in March at Rani, when the people who came back from Italy became positive. What we did was the entire route map was set for individual patients who became positive, like how they landed and what mode of transportation was done, and who were their immediate contacts whom they know they have been in contact with, at what particular point of time, what they were doing. Suppose they had a coffee at one of the restaurants, and at that particular time this particular person was having a coffee, that was specifically marked in the route map, and any person who was in and around that particular area was actually traced. At the peak of the time, we had almost 1.9 lakh people under tracing, under isolation, home isolation or contact tracing, when we had the peak, the last peak somewhere in mid of March and the early April. So individual travel, transport, everything was traced out. And suppose the person has come by flight, so everybody in the flight was actually back traced, and they were asked to be in home quarantine for at least a period of 28 days. In case of there is any symptoms, they have to immediately report to their assigned healthcare workers, so that the patient can be brought in, and immediately testing was done. So the advantage of having an earlier testing was that whomsoever had symptoms, we had tested them, and who has come positive, we again did the same kind of contact tracing for these individual persons. So creation of route maps, and finally once the route map is done, and we actually had an entire line listing of patients who is positive, and separate for the suspect for individual patients, so that whatever branches out, we can individually trace, so that the number of persons whom they transmit is very less. Because the initial, once you cut down the initial R naught factor, then the subsequent R naught factors automatically come down.
Thank you, Dr. Vimal. Yeah, so a lot of questions are being asked about various orders of Kerala government. So I would request the organizers to just project the website address of the Department of Health Services of Kerala, so that the participants can actually refer to it later on. While they do it, I would take the next question. So there are questions about household contacts. So were household contacts included in pool testing in Kerala?
Household contacts were not included in the pool testing. If the pool testing, I think what they mean is pool testing of the for RT-PCR.
Yeah. So
Yeah,
they
it
are
was
asking
being
about that.
done when there was surveillance. We were having surveillance tests being done, and in some of the augmented surveillance was also being done. In some of the those situations, only the pool testing was done. Otherwise, individual testing is done at large in Kerala. Not household contacts were included, but positive contacts, whether household or all positive contacts between in those people, we had as per the guidelines we have tested.
Okay.
Contacts of positives, I mean. If a person is positive in that house and they are in the same close contact, that was tested.
So one question is how to separate a COVID and non-COVID block in a hospital.
It's already been discussed. It cannot be said, but we have to design in our own hospital, but it should be entirely separate, and there should be clear signage boards that the patient with COVID will reach only the COVID side, and non-COVID people will be able to freely and with fearlessly, they should be able to access to the other gate and other entrance and everything we need to design depending upon the institution facility available. But it is possible. That has to be done, and it has to be done with everyone together. Between who is in the non-COVID area and those in the COVID area, it should be comfortable for the either. And the patient should be clearly told where to go. An ambulance should be knowing where to go if they come with a COVID patient. That has to be with clear marking with signage boards. But it has to be customized.
Yeah, so there have to be engineering controls, there have to be
Yeah.
administrative controls, the
That has
building
to.
should be separate physically, the air handling units should be separate for these areas, there
Yeah.
should be no mixing of the ventilation, and all those measures, they are actually in detail. I hope the organizer are arranging to project the DHS Kerala website page so that people can actually see those guidelines. And these guidelines are actually available at the Ministry of Health and Family Welfare website also. In fact, I would request all the participants to regularly visit two websites, Ministry of Health and Family Welfare website and ICMR website. So ICMR website again is very important. The guidelines that we keep seeing in WhatsApp, sometimes they are fake. So you can actually go on to these two websites and see for themselves what are the guidelines that have been issued by the authorities and what are the genuine, you will find the genuine and latest guidelines over there. So one question that has come to us is, this participant seems to be a pediatrician. What are the precautions to be taken while attending lower segment cesarean section and in vaccination and OPD? So who will like to take this question?
Midun, would you like to answer?
Sorry, about the personal
What
protective
precautions
equipment.
to be taken during a
Yeah.
lower segment cesarean section and while organizing a vaccine session and during OPDs?
It is in fact the
Uh,
same, but Midun can tell about our something that we did.
Yeah, the main concern is about first of all having a separate area for the COVID suspects. Okay, you have to do a screening triage at every entry point of the hospital. Every entry point where patients can get inside the hospital, you have to have a separate triage screening point. Okay, you need to identify the suspects and separate them from the non-suspect. The suspect should be managed in a separate block or separate area. Okay, so this can be actually done by duplication. You need to have a lot of resources for this, and depending on the procedures which you are doing, you need to select the appropriate PPEs. Like in the OPDs, I think uh, a if you are if there is no risk of aerosol generating procedures, so you need to have a medical mask. You need to use your gloves, and if available, an apron. That would be the best thing. And you need to protect your eyes with goggles or a face shield. That's adequate in an OPD setup and even in vaccination setup. Now about a theater, uh, I'm not sure whether there is aerosol generation during lower section, cesarean section. There have been reports of the virus uh, in the peritoneal cavity, in the ascitic fluid as such. So if there is suctioning involved, I think you need to have specially designed negative pressure theaters for these, for doing these procedures, as well as you need to have your full PPEs. For any cesarean, any invasive procedure, you need to have your full PPEs.
Yeah, so that reminds me that in future there will be pre-COVID and post-COVID eras. So if those of us, Dr. Chandni and Dr. Vimal will probably remember that after the arrival of HIV, big time on the world stage, then there were lectures in the hospitals. There were across IMA and other professional bodies actually held these lectures where they said that you have to consider every person a potentially HIV positive. And that's how the universal precautions came to be practiced more widely. I think COVID is going to reinforce that and bring it to the center stage once again. So every person has to be considered a potential COVID positive person, and you have to actually don't get paranoid about it, but you have to actually take all the possible precautions as have been described by Dr. Midhun. Uh, there will be some measures which we can undertake immediately, like wearing a face shield, using a mask, using gloves, and then there will be some other measures like air handling units. Uh, Gone are the days of having air handling unit for large areas and large unrelated areas. Maybe we will have to go in for smaller air handling units specifically for one area, and then there is no mixing. The negative pressure OTs, yes, it will become important as we go along. So all these measures are actually going to be there. We have actually crossed the time of 5 p.m.
Can I make one comment?
Yeah,
because
please.
I've seen an interesting this thing, break the chain campaign. Break the chain campaign was very efficient in Kerala. And before concluding, the current message is SMS. SMS is sanitizer, mask, and social distancing. So it's so effectively going in Kerala, and the community participation is huge. And I've seen an interesting question. That's why I thought I'll add that before closing.
Yeah, and actually we can capitalize on this because it has caught the attention of everyone in society. I think we should actually capitalize on this and start educating people and start insisting upon observance of sneeze etiquettes, cough etiquettes. People can be taught about not to spit anywhere. All these things may actually end up making the public health scenario more better in India. We may end up reducing the transmission of other diseases. And I would like to take one last question related to that. One person has asked, what has been the experience of Kerala regarding other serious diseases in times of COVID? I know it may be a little premature to ask this question, but if any initial thoughts, any study has been done in Kerala on impact of other diseases, have we had a surge in, let's say, cases of
Non-COVID, you mean?
Yeah.
Yeah. There is in fact no additional surge. In fact, traffic accidents were less during the lockdown period because an alcohol was not available. There were many good things happened. Road traffic and accidents were really low, and I don't think there was a surge in cardiovascular or other diseases, but we don't know. Some of the diseases might have definitely suffered in delay in getting treatment.
Yeah, I think we will have to wait for some time for these impacts to come out in public.
Would you like
to
add?
Yeah, on group chat, Rahul has shared the website address of the Kerala government's Department of Health Sciences. If anybody is interested in knowing about other measures that we have not discussed, they can go to this website and see for themselves how they have gone about it. And we have actually run out of time. And I would like to thank all my panelists, Dr. Chandni, Dr. Vimal, Dr. Midhun, And I would like to thank the organizers for giving this opportunity to share the experiences with the learned audience. And I hope it was useful, and see you sometime soon.
Thanks
Okay.
so much. Thanks so much, doctors. Really, really appreciate you taking your time. That too in such uncertain times, where you know, I would have loved to extend this more and take more questions, but I know how important your time is right now. And yes, thanks so very much again, and wishing you all the very best of luck. And for the audience, if any doctor wants to volunteer with Project StepOne, please go on our website, which is www.projectstep1.org. And we're essentially building an army of doctors, and we reach out to you when only and only when a help is required, and we ensure that you know, patients that speak your native language are connected with you. So please join the forces and help us, you know, let us spread faster than the virus. And on that note, thanks so very much again. Thanks so much.
Thank you.
Thank you.
Thank you.
Thank you, everyone.